Thank you for joining us today. We have a pretty nice presentation worked out for you. We're going to be talking mostly on shoulder arthritis as opposed to other shoulder conditions or other joint conditions. And shoulder arthritis is pretty common. I'm going to talk about the prevalence and the background with how you get shoulder arthritis, a little bit of what happens when you see a physician and what they're going to do in terms of asking you questions and what type of examination findings they might be looking for, as well as coming up with a differential diagnosis or the other things that your shoulder pain could be besides arthritis. And then we'll talk about treatment options, which will include figuring out what your goals are. Is your goal pain relief? Is your goal to restore function? Is your goal to have a shoulder that's long-lasting? And in most cases, it's some combination of those three. Shoulder pain and arthritis are quite common, and there are some studies looking at the vast number of people, and even up to 20% of people over age 65 at some time in their life have pain because of shoulder arthritis, which is a pretty surprising number. Most shoulder complaints are not necessarily due to arthritis, however, and are due to issues with the rotator cuff, which is a combination of muscles and tendons surrounding the shoulder and the ball portion of the shoulder. There are about 200,000 shoulder arthroscopies or shoulder arthroscopic surgeries for rotator cuff repairs, and another 400,000 for rotator cuff irritation or tendinitis. So that number really completely eclipses by more than 10 times the number of shoulder replacements, which right now is somewhere around 30 to 35,000 a year in the United States. The shoulder is the third most common joint that's replaced after the hip and the knee, and the number of shoulder arthroplasties or shoulder replacements has gone up fairly steadily over the past 10 years, and is anticipated that that's going to continue to rise up to 2020 with somewhere in the neighborhood of 50 to 60,000 shoulder arthroplasties per year, or shoulder replacements per year. Now, to put that in perspective, there are probably 10 times that number of hip replacements, and maybe even 10.5 times that number of knee replacements. So a huge difference between hip and knee arthritis and shoulder arthritis with how many get replaced and how many need replacement. And I kind of joke with some of my patients that at least you don't walk on your shoulder, and that's probably the reason that most people don't have a lot of problems with shoulder arthritis. So where does arthritis come from? And this is certainly one of the things that I always try to figure out, and most physicians will try to figure out, because knowing the etiology or the cause of the shoulder arthritis becomes fairly important when you look at different treatment options. Especially if it's a young person, you really want to figure out the why before you come up with the treatment. So most shoulder arthritis is from wear and tear, which is osteoarthritis. Occasionally you can pinpoint one time of trauma to the joint, and the cartilage in the joint doesn't really like to have an impaction. So trauma, even if it's trauma from years and years ago, can lead to arthritis later on. You can have problems with your rotator cuff. So a long-standing rotator cuff tear that you've had for years and years can eventually lead to arthritis. And the reason is the rotator cuff keeps the ball centered in the socket portion of the joint. So if that is torn, the ball starts to ride up, and that asymmetric wear is like your tire being out of alignment in your car. So eventually the tread, or the cartilage in your shoulder's case, will start to wear off. So that's called rotator cuff tear arthropathy. Then there can be surgical things. The old school way of fixing a shoulder dislocation, if you look in the top left picture, there's a screw in the shoulder. That was from over-tightening the front tendon of the rotator cuff, and that particular type of surgery led to arthritis at an early age. And then there can be dislocations. The top right picture is an MRI of a shoulder that has a dislocation and a fracture, and the bottom picture is another dislocation, and those can all lead to arthritis as well. You can have a few other things that are much less common, and if you look at the bottom of the list, rheumatoid arthritis is at the bottom of the list because the medical doctors have done such a good job these days of treating rheumatoid arthritis before it really becomes an orthopedic issue. So it's really in the purvey of the rheumatologist and the internist to be treating rheumatoid arthritis medically, and rare these days for me to get someone with rheumatoid arthritis that needs an arthroplasty or a replacement. So when you come in to see me or anyone in the office, we're going to do a pretty good assessment of what's going on, what your problems are, what type of pain you have, and with what activities or what issues are going on with regard to pain in the shoulder or limitations in mobility. Pain at nighttime is one of the hallmarks of arthritis. It can give you a deep, achy pain in the shoulder, almost akin to having a toothache in the shoulder. That's pretty common. And you can lose range of motion, meaning you can't reach behind your back, you can't reach out to the side. You can occasionally have mechanical symptoms where the shoulder pops or clicks or almost feels like it's going to get stuck in one position before you move it around. On an examination, we do basically the same sort of thing. We take your arm through a range of motion, we try to figure out how much you can move it and then how much we can move it, with your pain being the limiting factor, of course. And then we also look at how much pain is in the back side of the joint, because that can really lead us or clue us in to this being an arthritic problem as well as just a pain problem. And then occasionally we will do selective injections, so either an injection above the rotator cuff or an injection actually in the joint, and that can help differentiate arthritis from rotator cuff problems or vice versa. Very often we'll do x-rays, and an x-ray or a radiograph is a great way to sort out what's going on. In long-standing arthritis, there are some pretty classic findings that you get. If you get to the point of needing a surgery, or that we decide together that we're going to plan on doing a surgery, a CAT scan, which is the bottom picture, a three-dimensional reconstruction of the shoulder blade, can be very helpful for me to plan out the surgery. So a CAT scan or an MRI scan are really good planning tools for surgery. But typically we can make the diagnosis on radiographs or x-rays alone. The gold standard for looking at arthritis, if you really don't have an idea of what's going on, is you look inside the joint. I would say that's a very, very unusual finding, that you have arthritis and we don't know it from beforehand, from the pre-op planning. But it is the gold standard because you look directly at the joint. And this picture on the screen is looking at the head of the humerus, and the head of the humerus in this picture has essentially no cartilage on it. So this area over here, there is no cartilage. This yellowish discoloration is the bone. It gives us a direct view of the area that's involved. You can look at bone spurs or remove some bone spurs. You can remove loose bits of cartilage and loose bits of things that are floating around the joint. So sometimes we use the arthroscopy for actually treatment of arthritis. The treatment consideration. So when do we figure out what to do with you? If we make the diagnosis of arthritis, there are many different things we can do. As I mentioned, you can do an injection, you can do an arthroscopy, you can do a partial joint replacement or a total joint replacement, or a special type of joint replacement called a reverse shoulder arthroplasty. There are many factors that go into deciding what to do and what might be best for you. Number one is your age. The younger you are, the less likely an arthroplasty or a replacement will last your lifetime. Most people ask, how long can I expect out of a joint replacement? And I'll get to that with a couple studies later on in the talk, but the ballpark is about 15 years before the surfaces start to wear out, and this is the plastic portion that will start to wear out. Also look at your occupation. If you're still working, if you do a manual labor job, doing a joint replacement, probably the wear and tear on that would not be tolerated very well in someone who does construction or heavy labor or a lot of repetitive overhead type lifting activities. So then we also look at your activity level, as what you want to go back to doing. Do you want to play golf? Do you want to play tennis? Do you want to do more active sports like skiing or contact sports? And that really helps us decide what is the right option for you and what's going to last the longest in your shoulder and provide you the most relief. So we look at the different characteristics of the arthritis as well, and that's where the MRI and the CAT scan come in, is we get to really get down to the details of, is there a problem with the alignment of the shoulder that we have to correct? Is there a problem with big, huge bone spurs everywhere? Is there a problem with the rotator cuff in conjunction with the arthritis? And all those things get factored into figuring out what is the best treatment for you. So we really try to individualize your treatment. It's not one size fits all. It's not arthritis equals a replacement. There are some very important non-operative treatments. Number one is anti-inflammatories like Aleve or Advil that can provide pretty good relief in the early stages of arthritis. As I mentioned before, sometimes we'll do a steroid injection or some other type of injection. So there's an off-label, FDA not approved use, but very well utilized in the knee for hyaluronic acid, which is essentially joint fluid. So we can put synthetic joint fluid into your shoulder joint just like you would do into a knee joint to provide a little bit of lubrication and a little bit of cushioning inside the joint. Additionally, we can put growth factors in. Something called PRP, or platelet-rich plasma, has been shown to have a beneficial effect in an arthritic joint. And then, of course, physical therapy. Very important to gain range of motion, to gain strength in the areas around the shoulder joint, specifically around the shoulder blade, and to maintain good posture. So physical therapy can be a very important adjunct, especially in the early stages of arthritis, to help you get through your pain, and also important to get you ready for a surgery. The stronger you are going in, the easier your recovery afterwards. The operative treatment basically is broken down into a total shoulder replacement, which is replacing both the ball as well as the socket side. And that's the gold standard. That's the standard to which every other surgery should be compared, because it has the best longevity, it has the longest, in terms of pain relief, the longest relief, and probably the best function. You have to look at the factors that go in. As I mentioned before, if you're a heavy laborer, if you're a young person under age 50, a total shoulder replacement may not be the best thing for you. So again, we really try to individualize the treatment, but the gold standard being total shoulder replacement, we compare everything to that. If you look at the right-hand column, the alternatives to that are doing something called a hemiarthroplasty, where we're just replacing the ball side. And that can be useful in a younger, more active person. There are some palliative things that we can do. As I mentioned, we can do arthroscopy, and arthroscopic treatment can get you range of motion, it can give you pain relief, and there are very few risk factors that can't be solved later on if we convert that to a shoulder replacement somewhere down the line. But it can give you a few years of pain relief if you choose the right patient and have the right indications for doing an arthroscopy, which is a limited incision, limited invasive surgery where we go in and basically clean stuff up on the inside of your joint. There are some reparative things that we can do. Again, younger patients, more active patients are probably better candidates for those things. And then in a more advanced problem where the rotator cuff is damaged, or in some revision settings, we do something called a reverse total shoulder arthroplasty, where we put the ball on the opposite side of the shoulder. And I'll show you a picture of that later on. So we talked about some of these things with shoulder arthroscopy. The indications are if their arthritis is focal or localized and more moderate, in early stages of rheumatoid arthritis or inflammatory arthritis, and the results, up to 87% of patients are satisfied for more than 2 years after this type of treatment. This is one of my examples of a total shoulder replacement, and this patient is the youngest person that I've done a shoulder replacement on that did not have rheumatoid arthritis. She's a 33-year-old woman who had a special area of joint damage from gymnastics. She had multiple posterior shoulder dislocations that were fixed with a couple different surgeries, and after one of the surgeries she ended up having a device put into her shoulder that started to wear the cartilage away. So she had something called chondromalacia of her shoulder, or complete damage of the cartilage surface. So she was a very young patient. This is a very unusual procedure to do in a young person, but she was completely debilitated with very, very severe pain and 2 young children at home, and she couldn't really cope very well without doing this. If you look at the left-hand pictures, those are pre-operative. So the x-ray up above, you can barely see any roundness to the shoulder here. The bottom portion here, same thing on the CAT scan, is the shoulder surface is essentially flattened right here. So her shoulder really didn't move very well. If you look at the top right picture, there is total shoulder replacement with the ball up here and the stem coming down here like that. So what does a shoulder replacement look like? Shoulder replacement has several different components. There's the ball component here, there's a stem component here. The ball typically is cobalt chrome and the stem is titanium, and they can be press fit or cemented in place. Most these days are press fit in place. The glenoid component, or the shoulder blade component, usually has little pegs on it or a little keel that go into the bone and fix it in place with cement. The outcomes of shoulder replacement are quite good. As I mentioned, this is the gold standard for arthritis. 93% of patients have survivorship, meaning the implant is still lasting and still functioning well at 10 years, and 87% at 15 years in several different studies. So patients in general report very, very good relief and very, very good function for a long period of time. As I mentioned, about 15 years is what you can expect out of a typical shoulder replacement. This is another person, again, very specialized case. This is a young person, very active, a 48-year-old United States Navy SEAL. So his goal was to be able to jump out of an airplane and to be able to run through the desert and to be able to put on a 100-pound backpack and run around with his shoulder being very, very arthritic. I think you can appreciate barely the big bone spur down here at the bottom of his shoulder, and that was causing him a lot of dysfunction. So I did a resurfacing hemiarthroplasty, where I just resurfaced the ball portion and didn't do anything with the socket portion. And again, this is a fairly specialized treatment for an unusual problem in a young patient. And this is what that implant looks like. So it has this little stem on it, and it's hollow at the top, and it serves as a cap to go over the top of the humerus. And this is what it looks like. It's press fit in place. You don't have to use any cement. It is still the same type of approach that we would do for a regular shoulder replacement. This is a little bit more complex problem. This is an older patient who had a fracture about 10 years before he came in to see me. The fracture got infected. The joint replacement that he had previously was loose and infected, and he needed a very unusual treatment. So if you look at the picture, this stem is loose. You can see the cement here has a clear area around it, and the cement is actually broken at the bottom of the stem. So what we ended up doing in that particular case was I took out the old cement, I took out the old implant, put in some antibiotics in this cement piece here, and then converted that to what's called a reverse total shoulder. So the ball is on the shoulder blade side. This creates a differential effect where the deltoid muscle can actually power the shoulder. The shoulder joint is a little bit more constrained with this type of implant, but in revision cases, this is probably one of the best things that you can do. In addition, this really is helpful when you don't have a functioning rotator cuff and you have arthritis together. So it has to be an irreparable rotator cuff tear and severe arthritis to necessitate this type of implant. And again, this implant is relatively new. It's been on the market in the United States since 2004, but it's been used a little bit longer in Europe. And the characteristics are, as I described previously, the results are not quite as good. These patients typically have worse problems in their shoulder, more difficulty getting back to normal range of motion. Still though, 78% are very satisfied, and more than 2/3 have minimal or no pain. So let's talk a little bit about why do you want to see someone who specializes in shoulder problems and specializes in shoulder replacements if you have shoulder arthritis. 75% of all shoulder replacements in the United States are performed by doctors who only do 1 or 2 shoulder replacements a year. And there have been a couple studies that look at programs that do more than just 1 or 2 a year, and they compare the results between those 2 programs. So one that does a lot of shoulder replacements and a hospital or a program that doesn't do a lot of shoulder replacements, and there's a difference. So if you go to someone or a hospital that does very few, you have a slightly higher complication rate than if you go to someone who does many shoulder replacements. And the irony of this study is many shoulder replacements was more than 5 a year. So if you look at shoulder experience, you definitely want to look around and talk to your doctor about what their experience is and how many they've done. That's a problem that you should ask basically every physician that you talk to if you're looking at a surgery, is ask them their experience and ask them what they've done in similar situations. Overall patient satisfaction is excellent. So again, we try to individualize the treatment to you. We try to individualize the care to fit your needs and what your problem is. Complications are unfortunately part of medicine and part of life. So I wish I could say that we don't have any complications whatsoever with any of my patients. But there are a few things that I always take into consideration. Complications are unusual. I always think about infection, especially with a joint replacement. I think about dislocations. You can have a fracture in the middle of the surgery where you fracture out the humerus. That's pretty rare. Or you can have failure of the glenoid side or the shoulder blade side. Again, that's pretty unusual. So the complications are very unusual. Less than 1% of patients typically will have a complication after shoulder surgery or after shoulder replacement surgery. What are the key success factors? You look at the condition and the quality of the bone around the shoulder, the type and the severity of the arthritis, the condition of the rotator cuff, the age and activity level of the patient, and you also want someone who's going to be committed to rehabilitation and committed to rehab and physical therapy afterwards is a really important component to you having a good result. And that brings us to our next speaker, Jennifer Lair, who will be talking to you about the physical therapy and the therapy after shoulder replacement.
Hi, I'm Jennifer Lair, and it's a pleasure to have the opportunity to speak with you today about the role physical therapy plays in treating patients undergoing shoulder surgery. I do want to take a moment, though, to talk about patients that come in with the onset of shoulder pain or new injuries and how physical therapy may be a benefit to them. When I evaluate a patient who's coming in with a new problem that has to do with their shoulder, I usually will hear of a variation of 2 different kinds of history. There's the patient that will have the single event. At one moment their shoulder is fine, they can identify the exact moment that the injury took place, and from then on there's a problem. For example, this would be the patient who took a bad spill on a bike or took a bad fall skiing. You know exactly when you injured yourself. However, the majority of the patients that come in with shoulder problems present in a different way, and it may go something like this. You suddenly notice that you're having difficulty sleeping on your arm at night, and that you're having disrupted sleep. You're constantly having to reposition yourself. And then you notice when you're driving perhaps that you can't reach into the back seat of your car and without getting a sharp pain. And over the course of a few more weeks, you notice that you're starting to use your other arm to do a lot of your activities, and you're avoiding the use of the injured or hurt arm. And basic activities for a woman, for example, to be able to hook a bra behind the back or style your hair, you're noticing that you're having difficulty doing these things, and at a certain point in time, you may be getting a referral to the physical therapist. Now, a lot of these symptoms are something that physical therapy can be quite helpful with, and there's a whole array of treatment techniques that we can use to help minimize and or eliminate these kinds of symptoms. However, there will be a number of patients who will begin a course of physical therapy, and these symptoms will not go away, and there'll come a time when the therapist and the patient are going to be looking at one another and thinking, well, we may need to look at what the next option may be. And at that point, the patient will often say to me, should I have surgery? And I often will pose the question back to the patient. I want you to answer the following questions and give this some consideration. How much is your day being worked around your pain? How much are you avoiding activities, turning down invitations to do things, all around the avoidance of pain? How much is your sleep being interrupted? The inability to get quality sleep is a big problem, and it's not something to be taken lightly if you are having difficulty getting comfortable in bed. Perhaps you're starting to notice that you really are using your other arm for almost all activities. You're avoiding lifting anything heavy off of your stovetop. You can't put dishes away overhead or empty a dishwasher. Those are just a few examples. When the answers to these questions become quite significant, this is when we're talking, it's really time to have surgery. And at that point, the next question that I'm almost always asked is, well, what can I do? What should I know ahead of time? What's it really going to be like if I have shoulder surgery? And having the relationship with the physical therapist often before surgery allows for some really candid conversations where we can lay out the lay of the land. What will you experience? What to prepare for? And I'm always of the belief that the more you know ahead of time and the more you can prepare, the less anxiety and stress you'll have around the event. So at this point, when the decision is made to have physical therapy, there's a number of things that the therapist is able to do with you. You may be continuing with physical therapy where the goal will be to improve and try to get as much range of motion and flexibility as possible. We want to strengthen up the whole, the rest of your body. Just because you have an injured right arm doesn't mean the left arm shouldn't be doing a strengthening program, your core, your lower body. We want to identify what a cardiac activity might be that you can do that won't cause pain. We want to get you in the best shape possible for surgery. And then there's things that you can be doing on the home front. For example, if you take your arm right now and place it behind your back, and I want you to now think about how are you going to get yourself undressed? How are you going to get your shirt off? How are you going to pull your pants up or down? What about shoes that require tying zippers, things like that? All of those things we want to have you kind of prepare and think through. Having large, oversized clothing can be very helpful to have available to you after surgery. Shoes that you can slip on and off. It will be very difficult to get tight pants on. Stockings are almost impossible. You want to think about your arm's going to be in a sling and you will have one arm to work with. So what can you do to make that as easy as possible? And then how are you going to eat? The ability to prepare your meals and to be able to clean, do laundry, things like that. So having people available to help you at home will be a big help to you. And for those friends or family members that are aware that you're having surgery and they say, what can I do to help? Ask them to bring you a meal. It may come in quite handy. The other thing I want to mention is that when I talk to patients post-operatively, one of the first complaints that the patient will share with me is that they're not getting sleep and that they're having a really difficult time sleeping. And the inability to sleep over time makes it harder for you to manage pain if you're having pain as well. What I do find is the patients that have reclining chairs are telling me they're spending the majority of their evenings in the reclining chair and they're actually sleeping quite comfortably. So I've learned to tell patients that if you have the ability to prepare yourself with a reclining chair to make use of that, it will become very handy. It may be your home away from home following surgery. Should you choose to have certain surgeries, for example, the joint replacement surgery, you will be spending 1 to 2 evenings in the hospital. And at that time, you'll be seen by physical and occupational therapy. They will come in and work with you, and the goal will be to get you up moving. We always want to get patients up out of bed as much as possible. We may begin some range of motion exercises with your involved arm. We want to make sure that you're able to do your basic life skills. Can you brush your teeth, wash your face? Is it going to be safe for you in the bathroom? There may be some special equipment that the occupational therapist will want to order to make it easier for you to dress yourself. And then we also want to look at your ability to walk. While most patients undergoing shoulder surgery are fully capable of walking, there will be the patient population that is coming into shoulder surgery using a walker. And your ability to use a walker following the shoulder surgery will not be possible. So the physical therapist will be troubleshooting and working with you to come up with the safest assistive device to make sure that you will be safe to go home. We always want to make sure that when we send our patients home that they're safe. At that, sometime after your discharge from this hospital, you will begin your outpatient physical therapy, and you will spend a good amount of time in outpatient physical therapy. So hopefully you have a good relationship with your therapist. The physical therapist at the first session is going to get a full history of how you're doing. We'll ask lots of questions. How are you getting through your day-to-day activity? How much help are you getting? Is somebody at home helping you get dressed? What can you do, and what are you doing with your other arm that you would otherwise be doing with your evolved arm? These are all things that we're going to want to address in outpatient therapy. We're going to begin your outpatient therapy, though, mostly in the area focusing on range of motion. And in the beginning, the range of motion will, in all likelihood, be passive range of motion. And what that means is you're going to allow the physical therapist to move your arm through all the various planes of movement. Now, this can be challenging for patients because you have to have a leap of faith that you're going to relinquish control of your arm to the therapist and allow the therapist to move you, sometimes into ranges that may be painful. I will tell some of my patients that are having challenges with pain that they may want to pre-medicate before these early sessions in physical therapy just to get you over the hurdle. But range of motion is a very important thing that the therapist will be working on. We want to avoid the buildup of adhesions and scar tissue and ultimately get you back to full range of motion. So the importance of moving the joint very early on will become something the therapist will really focus with you on. At a certain point in time, strengthening exercises will begin, and this is something the physical therapist is coordinating with your physician based on the parameters that the physician has laid out. And the strengthening exercises usually come about in different phases. We might begin with isometric exercises, and by that I mean that you are going to start to get a muscle of fire, but there won't be actual movement. So if I ask you to take your arm and push it into a wall, you're not going to push that wall away, but you're going to figure out what muscles would be needed to begin pushing into the wall. And we will start patients usually with a submaximal contraction. We just want you to find the muscles, how to get them working again, because they haven't been working, and now we need to kind of wake them up. So we'll increase the amount of isometric work that you're doing, and then at a certain point we'll switch over into active exercise. Active exercise is when you're moving your joint against gravity. You're bringing your arm up overhead, for example. You don't have any weights involved. The weight is the weight of your extremity, and the resistance is the resistance gravity is providing to you. So the physical therapist will often be helping you in the beginning with the active exercise because you won't have the strength to do this on your own. Eventually, you'll be moving into a more resistive strength program. And at this point, therapy sessions really go off in two different directions. Patients that are going to need to get cleared to return to a sport, to a very manually intensive occupation, are going to be put through a much more rigorous strengthening program than a more sedentary person who maybe, for example, walks for exercise and doesn't do a lot of overhead exercise that will require more aggressive strength training. We individualize all of our exercise programs based on what we learn about you and what your goals are. But regardless of whether you're going to get returned to an overhead sport or whether you're going to go home and maybe resume knitting or some kind of needlepoint work or computer activity, every patient needs to be able to get back full function. By the time you're done with physical therapy, we want you to be able to take a heavy coat and hang it in a closet, pull things down overhead from overhead shelves, be able to lift a pot off of a stove. Things like parallel parking, pulling into tight spaces, those are all things we want every patient to be able to do. And that is going to be where the therapy will lead you towards. The Novato Community Hospital has outpatient departments, physical therapy, and sports fitness. We have 2 locations in Terra Linda and in Novato, and the therapists there work strictly with patients that have orthopedic and sports-related injuries. At this point, I'm going to invite Dr. Solomon to come back up, and I hope that through your participation in this webinar, we have successfully addressed questions you may have around shoulder pain and diagnosis, how a shoulder is worked up, the various types of procedures that can be done to further define your diagnosis, and should you need surgery, some of the operative procedures that are available to you, as well as taking you through what you can anticipate on the post-operative side regarding your outpatient physical therapy. Thank you for participating in this webinar, and at this point we'll be happy to take questions. Dr. Solomon?
While we're waiting for some of your questions to come in online, there were some people who submitted questions ahead of time, and I think we can address most of those while we're waiting. There are some common themes to the questions. Number one is a combination between neck arthritis and shoulder arthritis, and in my office I see that very commonly. So that's one of the hardest things to differentiate is your shoulder pain or is your arm pain coming from your neck, or is it coming from your shoulder? And sometimes it's coming from both, and we have to differentiate one from the other. It can usually be done with a physical examination and being very discerning on your examination. And occasionally we can do it with looking at x-rays or MRIs of your neck or of your shoulder to figure out how much damage is in one or the other, or if there is damage in both. And again, it's not an uncommon thing to have a little bit of wear and tear in your neck, and that can affect the nerves that go down into the shoulder area. So pain that radiates down your arm below your elbow very often is coming from your neck. So that's one of the questions that we almost always will ask you is where is your pain located and what is the quality of your pain? One of the other questions that's kind of a common theme of the things that we got ahead of the webinar, how do you differentiate between shoulder arthritis and frozen shoulder? So a frozen shoulder is also something called adhesive capsulitis. So it's the area around the joint. Essentially there's a bag around the joint that keeps the joint fluid in. And the shoulder joint is a little bit specialized relative to the knee or the hip. It has ligaments that are almost integrated into the capsule. So any inflammation in the capsule will lead to stiffness in the joint. And usually we can differentiate that again on a physical examination, but occasionally we will end up getting an x-ray, and that will clue us in to one versus the other. There were some very specific questions, and I will address some of those as well, is how would you address a 10-year-old shoulder injury that doesn't have internal damage, but physical therapy has been unsuccessful over a number of years? And the person who was asking the question wanted to know about pain management other than medication. So that might be an indication if you haven't already had an MRI. We can really differentiate, again, based on a physical examination and an MRI of what exactly is going on the inside of your shoulder. If we can't figure out that way, occasionally an arthroscopy would be indicated where we can go in and clean things up, and that might give you longer standing relief. But again, I think that would be a little bit more unusual type treatment. Usually we can figure it out with injections, and there can be other things. I think physical therapy certainly has a role in a lot of those patients. Not every physical therapist is the same. Not every physical therapist has good experience treating shoulder arthritis. So just as you would shop around for your physician, you should probably shop around for your physical therapist and ask their experience. Jennifer, do you have any comments on that particular question?
No, I would agree. I think that there's varying amounts and there's great variation in the things that physical therapy can do, and it's always good to ask a therapist what their specialty is and really try to find somebody that is going to take the time to work you up properly and provide you with a thorough exercise program.
There's a specific question that came in, and we'll address that, and then I'll get back to some of the questions that came in before the webinar. So the question is, I'm a 31-year-old student who is disabled from overall chronic pain and fatigue. A car accident at age 15 caused herniated discs, bone spurs, and arthritis in the spine, right shoulder and right shoulder blade. Limited motion of the shoulder, pain and creaking and aching in the shoulder. Physical therapy hasn't been helpful. This is certainly one of those cases that you have to look at the neck and shoulder in combination and not as necessarily isolated things. So if the injury to the neck has caused damage to the nerves or an injury to the nerve that goes down into the shoulder that might cause some dysfunction in the shoulder blade. And if you think of the relationship between the shoulder blade and the shoulder joint, it's almost like a golf ball sitting on a golf tee. And if the golf tee is tilted, like if the shoulder blade is out of alignment, then the golf ball is going to fall off. In the shoulder, what that does is put extra stress on the joint and extra stress on the rotator cuff. So even subtle things that happen in the neck can have a cause or effect farther down the arm. So I think the first thing that I would look at in your particular case is look at the neck and figure out what needs to be done in the neck and how that might be affecting the shoulder.
We were asked a question about impingement and what kind of healing can be expected. This is one of the places where early intervention with physical therapy can be quite helpful. I think more and more when I look at root cause and I look at patients that are presenting with impingement, almost across the board, I'm looking at patients that have postural problems. And if you think about the amount of time that we spend sitting often in front of computers in poor posture, and then maybe we go to the gym and we really like to do certain exercises a lot more than others. So we end up building up the anterior chest and perhaps the bicep, and we kind of forget to strengthen the shoulder blade muscles and the muscles that really help support our ability to hold us up straight and keep our shoulder blades in the right position closer to the spine. So the more the shoulder blade comes forward and the more we sit in a rounded, folded over position, you will have much less movement in your shoulder joint than if you just get yourself into the best possible position and bring your arm overhead. So over the course of time, the more your posture gets further away from the neutral position and the more your muscles are tightened and not able to get through the full range of motion, you're starting to get friction and impingement of tendons and ligaments within the joint. And if left unchecked, that can start to become more of a problem with the formation of bone spurs perhaps, and you would see indications for the start of little tears in the muscle tendons, and it could eventually become a surgical problem.
I think that's a great segue into the next group of questions that we had ahead of the webinar, which is about the relationship between rotator cuff and arthritis. And certainly, as I mentioned in the talk, if you have a rotator cuff tear that has been unaddressed for a long period of time, it can cause a misalignment in the shoulder where the ball starts to ride up and you get edge loading, just like you would in your tire on your car where the tire's out of alignment, as I had mentioned before. So the relationship certainly is one of wear and tear over time because the ball isn't centered anymore. And certainly rotator cuff problems alone can cause you quite a bit of dysfunction. A fall leading to a rotator cuff tear or just an attritional tear can lead to problems without having arthritis at all. So you can be very weak, you can have quite a bit of pain. Again, most of the time we can differentiate this based on a physical examination, but sometimes it does take a more advanced study like an MRI to really look inside and figure out what's going on. One of the other questions that we got was specifically related to having had previous surgery and wondering if impingement problems can come back. And I think this is a great question for Jennifer. It goes along the line with the previous question, is if you have issues around the shoulder, how do you keep them from coming back?
So again, the importance of having a balanced exercise program. So we want to make sure that you are strengthening the posterior muscles of the shoulder blade and the extensors of the spine, in addition to strengthening the actual rotator cuff muscles, which are the muscles that work on bringing the arm overhead and out to the side. And having a program that's well designed to balance out those muscle groups. The biggest challenge we have when we begin strengthening a patient that's had a shoulder surgery, rotator cuff surgery in particular, is we ask the patient to bring the arm overhead and they'll start a movement that will look like this. And the inability to stabilize the scapula to the spine is a problem, and that's something that the physical therapist will work with you on right away and get those muscles stronger. And then a good stretching program, we want to make sure that you have the ability to maintain your range of motion. So sometimes the use of a roller where we can get your shoulders stretched out and you can move beyond what you could do if you were just on the floor, where the floor is going to impact your ability to get your arm behind you. So a combination of stretching exercises and postural strengthening, rotator cuff strengthening, those are all very important things that kind of keep you out of the doctor's office in the future.
There's another great question that we had about when I get pain in my shoulder, the clavicle pops near the sternum. So on the chest wall, this person is getting a popping sensation. If you think about how the shoulder moves, it's one big kinetic chain. So the shoulder joint is the humerus and the scapula, which is the shoulder blade. The shoulder blade connects to the chest wall by the muscles around it, but also by the clavicle or the collarbone. And that connects to the sternum, which is in the middle of your chest. So if you have an issue in the shoulder joint, very often you'll feel it farther in on the kinetic chain, and if you have a problem in on the kinetic chain, you feel it farther out on the shoulder. So very often we get patients who come in and they have these little pops or clicks around the chest that are related to how the collarbone is moving on the sternum. So sometimes it's frank instability where the clavicle is moving back and forth. Sometimes it's just a little bit of wear and tear in that joint, and the wear and tear, which is arthritis, is causing some clicking and popping. We see that in the elbow as well. So if you have a stiff shoulder or an arthritic shoulder, or your scapula isn't moving correctly, you can definitely get elbow problems and elbow pain because of it. So again, one of the questions that we will always ask is, where do you feel your pain? Do you have pain around that area? And if you have pain down in the elbow, we want to know if it's radiating pain going all the way down the arm, or if it's just an isolated pain that's because your shoulder isn't moving properly.
And I think along the lines of addressing some of the problems where neck posture and shoulder posture become problematic, like Dr. Solomon was saying with the golf ball example and the tee, if you have your neck in the wrong position, and for example, if you tend to sit really slouch, and I'll do this for you in the camera, if you tend to sit really slouch, really the force of gravity, your head weighs 8 to 10 pounds, gravity just really wants to pull your head down. Well, the only way you can bring it back up is by using a lot of extra force in the neck extensor muscles. These are tiny little muscles that get put to work far harder than they were designed to. So you're using the wrong muscle to hold your head up because you're too rounded over. And then in that position, again, if you're moving your arm, everything is in the wrong position, and it causes excess wear and tear and fatigue and often headaches. So I'll have a lot of patients that may come in with neck and shoulder pain, and they also will describe headaches. And often if you can just get somebody to be more aware that when you sit up straight, your head is sitting on the tee a lot better, for example, that's going to alleviate some of the shoulder pain. So we really look at the whole body. You can't just take a problem in its isolation. You have to look at the joints that it's attached to, that it's near, the impact it's having on the other side. Oftentimes, I'm sure you'll see this, where a patient will come in with symptoms on one side, and because they're favoring and using their other arm for every activity, you no sooner get finished taking care of one side that they're coming back to you with symptoms on the other side. And so early intervention, getting involved with care early on before you start to have this excess wear and tear going on, can be very beneficial.
Absolutely. A couple more specific questions that go along with the theme of the rotator cuff and how the rotator cuff relates to shoulder pain and shoulder problems. How does the rotator cuff tear? So if you think about the rotator cuff being very similar to the fan belt in your car, every time you turn on your car engine, that fan belt is working. It's moving around constantly. So the rotator cuff is a group of muscles and tendons. The muscle starts on the shoulder blade, the tendon wraps around the ball, and they have specific functions with lifting up your arm. So when I do this, my rotator cuff has to work. Without the rotator cuff, I won't be able to lift up my arm. So if you fall on the arm, that could be a traumatic injury, and the tendon just starts to pull apart and separate. But you can also have a tear very similar to the fan belt, that it just will wear over time, and you don't really know it until all of a sudden it breaks completely. So you can have an attritional tear just like you can have a traumatic tear. Most of the time you know when you have the trauma. Sometimes you don't really know when you have the attrition.
Exercises that people are very curious about, exercises that are specific to the rotator cuff. And it's always hard to give exercise prescriptions in this kind of a format. But in general, the muscles that are, the function that the rotator cuff does is bringing the arm overhead. It's also very powerful in bringing the arm out to the side and bringing the arm across, and to a certain degree reaching behind as well. And so an exercise program that involves those kinds of muscles, often there's a great series of exercises that can be done with a TheraBand. We'll put patients on some home programs with varying degrees of resistance for achieving rotator cuff in a series of simple exercises that they can do on an ongoing basis.
Another question that came in: I've been diagnosed with shoulder arthritis, likely resulting from an old injury. One symptom is popping of the shoulder joint, often without any prompting movement, and it feels as if the shoulder is popping in and out of joint. Very often, when you have arthritis, there can be loose bits of stuff floating around, and that bits of stuff is cartilage. So if you have a piece of cartilage that's getting stuck on the inside of the joint, it might feel like it will pop suddenly or get stuck suddenly in one position. And it doesn't take a lot of motion for that to happen. So even at rest, a little piece of cartilage can get stuck on the inside of the joint. The other thing that can happen is if you have damage to the bicep tendon, the bicep tendon can either flip into the joint or be subluxed out of a little groove that sits in the front of the shoulder. And if your bicep is subluxing in and out of this little groove, you'll feel a pop, and it will feel like the shoulder is incredibly painful for a short period of time until it goes back into its groove or back into a more comfortable position. So the popping that you get, it would be unusual without a previous dislocation or severe injury to the shoulder to have the shoulder popping in and out of joint, but it might be something getting stuck inside the joint that's causing that. Exercises to heal a rotator cuff. That's a great question. And one of the things that we really didn't address while this webinar topic was mainly on shoulder arthritis, I think it's important to know that not everyone feels the same injury in the same way. So we might have a patient come in to see us who has a completely torn rotator cuff, and yet they're very, very functional. So how would you address that patient, Jennifer? They come in and they have a little bit of aching in their shoulder, and you know from the doctor or from your examination that they have a fairly badly torn rotator cuff, and yet they're fairly functional. What would you do for them to keep them active and keep them as pain-free as possible?
One of the things we will do with all of our patients is at the start of treatment we have them complete a survey which really identifies where they are having impairments so we can figure out how best to help. So a patient that has a fairly weak rotator cuff but maybe isn't in a lot of pain, we want to get them as strong, we want to try to get the surrounding muscles as strong as possible. Again, we want to address neck and upper back posture and get their posture in the best possible position, get them to be able to sustain those positions over time. It really does take time to change your posture, and I will often work with patients and simply say, shoot for 50%. If 50% of the time you stop yourself and you do a quick check on how your posture is, if you're in a good position, you're well on your way to making some long-term changes. And there are a lot of patients that can get by with torn rotator cuffs. Again, if you're not trying to do a lot of overhead activity or you're not involved in competitive sports and things like that that involve a lot of upper body work, you may be able to get by without a functioning rotator cuff if all the other muscles on that side are in good shape. Building up more deltoid strength, and again, keeping the muscles that attach the shoulder blade to the spine. And an example would be being able to pull your shoulder blades back to your spine or do a shoulder roll up and back and try to work on keeping the back and down position as your rest position rather than the forward position here, which a lot of us tend to get in as the day gets late, and especially if you're working in front of a computer. quite challenging in this day and age for people to really keep their posture in a good position.
A couple more really good questions. So this is concerning a fall just a week ago, and this person landed on their backside and hit their shoulder on the way down. They know that there's no fracture. What should they do? I think the first thing is, how are you doing? If you're getting better, then you probably don't really need to be doing a lot different than just getting your range of motion back. But if you're still having fairly acute pain or fairly specific pain, especially if you're weak, especially if you can't move your arm, and especially if you have pain that is radiating down your arm, you should probably come in and get seen. And certainly, I think most of the orthopedic surgeons in this county are pretty accessible. My office, we try to be accessible, especially for acute injuries within a week or even quicker. So you can sometimes even get same-day appointments. And I think if you already have a relationship with a physical therapist, it would behoove you to go in, because they can very often give you little tips that will make you feel better very quickly. And most great physical therapists like Jennifer will be able to do an assessment and figure out if they need to get you over to see a physician or not.
And it's not an unusual experience. If I'm working with a patient, I'm really finding, for example, if a patient has been referred to me through a primary care physician and I'm working with them, and what I'm seeing is really speaking, I need to get an orthopedist involved in having relationships with your physicians. I'm often texting or calling you that I need you to help me with a patient, and those kinds of relationships are just wonderful to have. And it's important that the physical therapist and the orthopedist work very closely together.
We'll do one more question, and this question is about having aching and stiffness in the shoulder in the morning that resolves throughout the day. This is a young 43-year-old gentleman, and he says every morning he wakes up and his shoulder is stiff, and throughout the day it seems to get a little bit better, but he goes through that same pattern over and over again. Could this be arthritis? The answer is yes. Morning achiness and stiffness in the shoulder in the morning is a very common thing with any joint that has arthritis. So you might have that in your knee or in your hip, and it can be one of the most common complaints is it just takes a little while to get going. I think the other thing that happens during the day is very often we have lots of distractions. So you don't necessarily think about your aches and pains during the day, but at nighttime it really comes out.
Well, and you think about the fluid that bathes the joints. And if you're sleeping and you're sedentary, and literally the synovial fluid isn't circulating in the same way that it does when you're up and moving around and doing a lot of activity. And so the synovial fluid is essentially the oil that keeps the joint moving well. And first thing in the morning, that joint has been stationary, and you need to kind of get it working again, get it lubricated. And that's a very classic complaint that we'll hear with patients that have arthritis.
Right. That's a wrap-up for our webinar. I want to thank you all for participating, and just as important, we'd like you to go to the evaluation section and complete the evaluation. But Jennifer and I really appreciated your participation today, and thanks for joining us this afternoon.
Feel free to call if you have additional questions. Thank you very much.
Thanks.